Hey everyone, I think we'll get started today with our first workshop. On behalf of Monash DeepNeuron and MYMI, I'm super excited to invite you all here to our AI in Medicine workshop series. I'm Rebekah, I'm the current team lead of Monash DeepNeuron. So I'm going to start off by telling you a little bit more about what you'll be learning over the 4 workshops. You'll also hear a little bit about what Monash DeepNeuron is, but before we do that, I'm going to just start with a few general housekeeping items. So as I can see you all are now, please do stay muted unless you have a question. If you do have a question, please raise your hand or just post your question straight into the chat, and we'll try and get into the chat for all the questions as soon as we can. If you do have headphones like I've got right now, I would ask that you do plug them in or connect them while I'm talking, so that later when we go into our breakout rooms to discuss with some of the other participants, people won't be distracted by any notification tones you have. So back to the workshop series. In these workshops, we'll be taking you through the process of developing AI for medicine. So today we'll be starting off with a little bit of background into medical diagnosis. You'll then learn about how you can create your own AI models for medical diagnosis, and then how to productionize these models so that they can be used by actual medical practitioners rather than just stuck on your own computer. Once we've discussed all of that, we're also going to be discussing a few of the ethical considerations that we have to make in doing work or research in this area. So if you haven't heard of Monash DeepNeuron before, we're an engineering student team based at Monash University. We're composed fully of students, with students studying engineering, of course, but also some students studying medicine, IT, and commerce, just to name a few. And we've also got a range of students from different levels. So we've got undergrad students, masters, and PhDs. We initially started with just a focus on AI, but more recently we merged with the Monash Student Cluster Competition team, and we're also now looking at high-performance computing. Our team's vision is to empower, engage, and educate students, researchers, and the community like you all here today about artificial intelligence and high-performance computing. If you're interested in either of these areas, or if you just find what we're doing in these workshops really, really interesting, I would encourage you to apply for our team. We'll be opening up our recruitment really soon, so keep an eye on our Facebook and LinkedIn pages and also on our website. On that note, I'm going to hand over to Leah, who's going to tell you a bit more about MYMI and also what you'll be learning today.
Awesome, thanks for that, Beck. So my name is Leah and I'm one of the engagement directors for MYMI. So just a little bit about MYMI and who we are and what we do. So MYMI is an interdisciplinary team at Monash University, and we're focused on bringing together undergrads, postgrads, early career researchers, academics, and the broader community to achieve positive impact through medical technology and biomedical innovation. So our vision is to connect young people with academia, industry, and community, and drive innovations in healthcare and medical technology. So we've got a couple of projects running right now. And one of our branches also is engagement, in which we try and run events for the wider community, just so everyone can get a bit of a taste of what MedTech is like. So a little bit about what's going to be happening today. So like Beck said, today's workshop is all about the clinical and the medical component of AI in medicine. So we're going to start off with a little presentation on how diagnosis works, a little practical side where we're going to break you guys up into smaller groups and work on some case studies. After that, we've got another presentation on how AI works in medical practice. And then at the end of the workshop, we've got a special guest, Dr. Traversal, who's going to be joining us. So Jarrell is a medical doctor and researcher at the Alfred Hospital, and he does a lot of work on the intersection between artificial intelligence and radiology. So he's going to be joining us just to talk about his experience with using AI and where it is right now, currently in the field. So yeah, so I think we'll get started. So I'll pass on to Carlin, who's going to be running the first part of the workshop. So Carlin, you can take it away.
Okay. Thanks, Leah. Nice to see you guys all here. So my name's Carlin. I'm one of the engagement officers at MYMI. And today we'll be starting off by giving an introduction of the typical process of medical diagnosis, so that you would learn some of the considerations that might be taken when developing an AI. So starting off, we have a presentation from one of our fellow MYMI members, Alisha, who will take you through the process of medical diagnosis, with a key example being malaria.
Hi, my name is Alisha, and I'll be running this section of the workshop along with Carlin. The purpose of this section is to go through the process of diagnosis. This will not be in depth. It will mainly be going through the principles so that someone from a non-medical background can understand the process a doctor has to go through and the challenges they may face. This will set you up with the knowledge you can use in future workshops. In terms of the steps that the doctors go through, first they take the history, so talk to the patient. Then they conduct an examination to look for any signs of what the illness might be. They then use that information to come up with a list of differential diagnosis, so all the possibilities of the illnesses that they may have. They then conduct investigations to rule in or rule out the list of differentials that they have made, and this is the process I'll be going through. I'll be using chest pain as an example to go through this process. So with the history, they first need to ask about demographics, so name, age, and occupation, as well as taking note of their gender. This is important because the diseases that affect the elderly are different to what affect the young. The same occurs for men and women. We then ask what is wrong. So the technical term for that is presenting complaint. So in the case of chest pain, we would ask when it started and where the pain is and all of those kind of details to get a better picture of what the problem is. Then we would conduct a system review. So for chest pain, it would either be cardiac for the heart or respiratory for the lungs to identify any conditions that it might be. We also need to ask about past medical history and any medications they are on, because this might be an exacerbation of a disease they already have, or the diseases they have might predispose them for another illness. Then we need to ask about family history, because things such as cancer might run in the family. We also need to ask about social history, so what their stresses are, what their living situation is, to provide a complete picture of the patient. Next, we move on to the examination. We always do vital signs. So that is the temperature, the heart rate, blood pressure, respiratory rate, and oxygen saturation. This will tell us if the patient is generally well or unwell, which tells us how urgently we need to act. Then we do the examination of the system that came up during the history. So in the case of chest pain, we would listen to the heart and lungs. Using all that information, we make a list of the things that the patient might have, which we call differential diagnosis. This can be divided into what is most common and what is most serious, so the things that we can't miss. So in terms of chest pain, an example of things that are common are muscular strain, reflux, so when the stomach acid comes up higher, you can get pain in your chest, or a panic attack. Some of the most serious things that we can't miss, so we always look out for, are heart attacks or pneumonia, which is a bacterial infection of the lung that can be quite serious. Then finally, we use investigations to confirm or exclude that list. As we have a public health system, we can't just order whatever test we want. We have to order the least amount of tests possible. In the private system, you can order whatever you want. So we start with the least expensive tests that we can do at the bedside. For an example, an ECG or echocardiogram that measures the heart and tells us if the patient is having a heart attack or not. The next step up is doing blood tests. So we can do a full blood count, which is looking at red blood cells, white blood cells, and we can also do troponins, which would also tell us if the patient is having a heart attack or not. And then finally, if necessary, we order imaging. We leave this to last as it's more expensive than the other two categories, and a couple of the imaging, such as X-ray and MRI, expose the patient to radiation, so we want to reduce that risk if possible. I'll also be talking a bit about malaria as well, since the next few workshops will have an emphasis on this disease. So a bit of background first. So malaria is a mosquito-borne disease that is most commonly found in sub-Saharan Africa. So as you can see on the map, it's the orange section. There are many different species of mosquito, but the one that we worry about most is P. falciparum, as this is the most deadly species. In terms of the history and exam, the key history point that we need to get is their travel history, so where they have gone to. If they have travelled to sub-Saharan Africa or any tropical region, that is immediately a risk factor for them getting malaria. We also need to check if they've used insecticides, because that lowers their risk of mosquitoes biting them and then lowers their risk of having malaria. The other key history fact we need to get is whether they have a fever or not, and if that is fluctuating. So if they're spiking high temperatures and then coming back down to normal and then getting high temperatures again. The other symptoms that people with malaria have are not specific. So this can be like vomiting, diarrhea, general muscle pains, headache, so things that don't point to a specific disease. In terms of examination, we just do the vitals to see how unwell they are. We don't do a specific examination as there isn't a specific organ to examine. So the differentials or potential illnesses that they could have can be divided into from travel and common diseases. So there are a lot of diseases that people can pick up overseas, and some of those are listed here. This is not a complete list. And then we also need to consider common things. So even though they have gone overseas, they might have just picked up the flu and be presenting with that. So the investigation we need to order for malaria is the thick and thin blood smears, because that will tell us immediately whether they have malaria or not. So the thick blood smear is for the detection of parasites or the mosquito, so we can see if they have it or not. And then the thin blood smear is to tell us the species of mosquito, which is important because, as I said earlier, there is a species of mosquito that is particularly deadly, and we need that information so we can act on it quickly. Another point to note is that there are also rapid diagnostic tests that are used in resource-poor countries that don't have access to a laboratory. However, because we're in Australia, we usually have access to a lab, so we don't really use those. We use the thick and thin blood smears. So the process of this is that first we need to get a bit of blood, so that's usually through a skin prick. We then smear that blood onto a slide and then stain it with the stain. We then look at it under a microscope, and you can see that process here in the pictures. So the stain can either be used to stain the nucleus, which would come up as red, or can be used to stain the cytoplasm, which comes up as blue. We generally use the cytoplasm blue one because that is easier to see as the cytoplasm is larger than the nucleus. The appearance of the stain can vary according to the species of mosquito producing the malaria or the life cycle stage. And here are some pictures of examples of the different types of stains we can see. So these are all malaria stains, but these are just different life cycles and different species. So this is something that we need to consider when developing a model to recognize the parasite, because these are all indicate that they have malaria, but just different stages of the disease. So you can try it for yourself here to see if there are any infected malaria cells present, and if so, how many. Okay, so as you can see in the solutions, there are 9 malaria cells present, and you can see that with the blue dots in the red circles. So the pros of diagnosing by microscopy is that it's a simple and common technique. It can provide valuable information within a few hours of blood sample collection. So this can include the presence of parasites to identify the species and calculate the percentage of infected red blood cells. And it can help guide treatment decisions quickly. The cons are that it's a human doing this. So it's only as reliable as the labs performing them, and it's prone to human error and bias. It can have poor sensitivity and specificity, and it also often involves manual counting of the blood cells. So if the blood sample you get doesn't actually have any malaria cells in it, then you can have a false negative. I'll also talk a bit about the biases and difficulties in diagnosis. So there's recency bias. So if a doctor has recently seen someone with malaria, that is obviously in the forefront of their mind, and the next patient they see, they will obviously be thinking about malaria and trying to fit the diagnosis into malaria. There's expertise bias, so if a doctor has experience in a specific area, they'll have more knowledge about that, and so they'll be more likely to diagnose based on that specific knowledge. There's patient bias. So obviously this is a patient-doctor interaction. If the patient is rude, then it can affect the doctor's decision-making. And if there's any barriers to communication, such as language, that can also affect the information that the doctor has to work with. There's also premature decision-making. So if all the information they have so far, like there's a fever that's fluctuating, they have a travel history, their mind immediately goes to malaria, but they need to look at all possible diagnosis so they don't miss out on anything. So they need to do the full history and full examination before they jump to conclusions, essentially. A couple of other things that make diagnosis difficult is that people don't always present the way the textbooks say they should present. So with malaria, there's a lot of vague symptoms, so like the muscle aches, the headaches, the vomiting and diarrhea, that don't immediately point towards malaria. And the other thing is that we need to start with a long list of differentials and then narrow down. When the human mind naturally jumps to shortcuts and wants to get there the quickest way, which isn't always the best way to do it. So now we have some practice case studies. There are 3 examples of patients who may or may not have malaria, and your job is to identify who of the 3 display symptoms and have results that are associated with this disease. You'll have 10 minutes of discussion among your peers.
So, special thanks to Alisha from MYMI who made this presentation for us, and I hope you guys learned a bit about how the medical diagnosis often works when it comes to identifying the presence of disease. So now what we're going to get you to do is we're going to provide you with 3 case studies as mentioned by Alisha. And we want you to practice and have a shot at seeing if you can identify someone who may present the symptoms of it or may be diagnosed with something else. And through this, we hope to help you develop a small mindset that may help you in future workshops of identifying malaria and some of the considerations that might be taken when doing so. So for the case studies that we will be providing, there'll be 2 sheets. The first sheet will present you with just the simple clinical symptoms that a patient may present to a doctor. From this, feel free to use Google or the knowledge that you've just learned to see if you can identify with your peers whether or not this patient has malaria or not. Quite often in cases like this, we'll have, as Alisha mentioned, blood samples will be taken and sent to laboratories to verify whether or not malaria is present. So the second page of the case studies will present you with some blood samples through microscopy. And your job is to verify whether or not your initial diagnosis of malaria is correct or not. And the main focus is to just look whether or not you think you can see the presence of the parasite in the red blood cells. So we'll give you about 10 minutes or so to discuss with other members in your breakout rooms. Feel free to introduce yourself to each other and get to know one another, and just have a shot and see if you can have our diagnose whether or not our case studies have malaria or not. The case studies will be, I'm going to share you a link in the all chats that have the case studies. So please click the link and it'll take you there. And do let us know if you're having any issues with accessing these files. We'll split you off into breakout rooms now.
All right. Well, hey guys, my name's Andrew, and I'm here to sort of talk about like a brief sort of, I guess, high-level overview of what types of AI that we could potentially implement in medicine and medical diagnosis. Before we get started, I'm just really curious because I asked this question in the breakout rooms, but we didn't get a chance to respond. What does everyone think of like the potential of AI and how it can be implemented in just any field? So maybe it could be medicine or mechatronics and whatnot. Just chuck it in the chat. Just trying to get a vibe of like what everyone sort of what everyone thinks about it. Lots. Okay, 100%. Interesting. Yep, anything with image recognition, that's a really good point. So diagnosis, microscopy, world domination, that's definitely a potential. I don't think we're there yet, but we'll get there. And there's a lot of chat flowing. Reduce bias, that's a good point if we use it properly. Reading neurons. Sorry. Oh no, the chat's going too fast. Give me a sec. Here's who are disabled. That's a really good point. Yeah, I think Elon Musk was actually doing that with the ear implants. So you can actually listen to music with like implementations on the side of your head. Prediction, data collection, improved precision. Okay, cool. So I feel like everyone's got a pretty good idea of fast testing, yep, of what AI has the potential for. So we'll jump straight into it. So when I talk about AI, I'm referring to artificial intelligence. That's what it stands for. So, which is a pretty broad umbrella term, which consists of a lot of different categories. So artificial intelligence as a whole describes any type of program that can sense, reason, act, or adapt. So in other words, it's something that mimics what we refer to as human intelligence. And if we hone in on this part, I'm sure a lot of you have heard of or are familiar with the term machine learning. So that's a much more specific subcategory of artificial intelligence, which sort of describes an algorithm or program which learns what it's supposed to do based on iterations of doing the same thing over and over and over again. The theory behind machine learning concepts come from the field of statistics, and there's a lot of different types of them. But in terms of applications in medical diagnosis, what we're really interested in, and which is actually one of the most popular methods of machine learning, is called deep learning and the use of neural networks. And it turns out that, yep, so for all the different approaches, out of all the different approaches in machine learning, neural nets is by far the most promising technique within the scope of artificial intelligence that can be applied in medicine. And because of its popularity, the term neural network and deep learning is often used interchangeably with machine learning and artificial intelligence. But just for the sake of this presentation, I will be referring to AI, machine learning, in terms of neural networks. So when I say AI, what I actually mean is specifically neural nets. And yeah, so the inspiration of neural networks, as the name suggests, come from how neurons work. So neurons are actually the building blocks of our brain. And, you know, as like research says, that clusters of neurons work together and interact with one another dynamically in sort of like, yeah, so dynamically in different portions of our brain to make us sort of conscious, and which is what drives us to do different things. And I think a few decades ago, people actually developed mathematical representations of how neurons work. So essentially, normally neurons, you have action potentials or electrical signals going into the cell body, and the cell body sort of interprets this and sends an output signal. And we can actually represent this as like a math formula of inputs in numbers and outputs in another number. And the neural body, which is represented here, is essentially a function which combines the inputs. Yeah, and then so if we have a lot of the neurons together lined up, you can see we can call this a network of neurons, and hence the term neural network, right? So we're not really creative with how we name these things. Okay, so moving on, one of the most sort of developed applicational areas of neural nets is image recognition. And if we think about image recognition, so everyone a few real life examples would be, think about Tesla self-driving cars. They use that to determine who's on the road and what's on the road. Also facial recognition for unlocking your phones. And, you know, if you use Snapchat or if you use Instagram, the facial filters, they all use image recognition to detect faces and stuff. And if we talk about it in terms of the medical field, think about any type of radiography, so X-ray, CT scans, MRIs, etc. So these can all be categorized in terms of images, and we can implement image recognition techniques to solve problems. And these subcategory of neural nets are called convolutional neural nets. And as we can see here, that the inspiration from convolutions actually arise also from a biological background. So you can see here that this image essentially depicts what actually happens in our eyes as we see images or we look at things. So pretty much this is the surface of our eyes, and as light or photons hit it, it undergoes electrical sort of changes, and you have rod cells and cone cells which receive this information and passes it on to to neurons that are deeper into the eye. And what's really interesting here are the bipolar neurons. So what they do is they take an aggregate of the information, right? So you can see that this one takes input from four different rod cells and combines it into a singular sort of information to pass it on to you know, optic nerves, which goes into the back of your brain for image processing. And so the process here is what really interested most people. And now what we've done is that they've developed ways to incorporate this in terms of, like, say, programming and convert it into a neural network. So what they do is, say if you have an image here of a car and you have many different pixels, what this does, what a convolution layer essentially does, is that it takes an aggregate of all the neighboring pixels into a singular sort of point of information, and it drags that on deeper into the neural nets. And this actually, and then we process them into a singular value. And this is pretty much how a convolutional neural net works. And one of the best examples of this actually in action was sort of classification of skin cancer using skin lesions, which was published about 3 years ago in Nature. So we look at skin lesions, as you can see here, and we determine, based on a multitude of factors, whether or not they're cancerous, or if it's malignant, so if it's really dangerous, or if it's benign, if it's not dangerous. And in terms of medicine, this is really important, because if you have a skin lesion and if it's malignant or if it's really cancerous, you want to get rid of it. But if it's benign, you don't want to get rid of it, because the procedure for getting rid of it could potentially be really dangerous. So the classification of malignant or benign is really important here. And oh, sorry, I'm seeing a chat thing. Not so good. Okay. So this was a huge effort in terms of, so the scientists try to build a convolutional neural net in predicting whether or not skin lesions are, you know, dangerous or not. And this involved a lot of data. You can see here about 130,000 images and a bunch of different diseases. And we've sort of, they've tested this against the accuracy of the model against a board of 21 board certified dermatologists to see whether or not the model is competitive in terms of that, in terms of diagnosis accuracy. And from the results here, as you can see, it's a graph on specificity and sensitivity. But what it actually says is that the further up the dots are on the top right of the corner, the more accurate we are at predicting it. So the blue line is how the model works, so how the model performs. The red dots are what the 21 dermatologists are able to diagnose based on the images. And the green cross is pretty much a general representation of how accurate dermatologists are in general. And as you can see here, in most cases, the blue line is actually more to the top right of the corner compared to any of the dermatologists, which indicates that the model that the scientists are able to produce is actually statistically better than dermatologists in general, which is extremely surprising and useful. in sort of medical diagnosis cases, especially because some of these dermatologists have decades of experience in terms of diagnosis. Could there be overdiagnosis? That's an interesting question. So I'm assuming what you mean by that is that if it's a skin lesion that is benign, so it's not dangerous, and the machine said it's dangerous, or if it's dangerous and the machine says it's not dangerous, that could be very problematic. And that's a really good point. And there's a lot of research going into how to sort of account for that. And I guess in terms of what you refer as overdiagnosis, you can also talk about, doctors can make the same mistakes in terms of overdiagnosis. But then if we just look at the performance of the models, we can see that the probability of overdiagnosis or misdiagnosis is much less in this convolutional neural net compared to dermatologists. Moving on, another really good example in a commercial sense is the creation of the application phase 2 gene by fDNA. So what they've done is that this model is able to detect an extremely vast array of genetic mutations, just looking at facial features of children. And some of these genetic mutations are incredibly rare and difficult to diagnose. And it may take up to decades for the family to determine irregularities or arrive at a diagnosis, which would have been too late because much of the disease is associated with growth disorders. And so therefore it's extremely valuable to create these novel ways of detecting the rare diseases. And this is a case where artificial intelligence and neural nets is like the perfect tool to do this, because it's incredibly difficult for doctors to diagnose just based on facial features. And one advantage of this is that it's capable of memorizing disease patterns of an enormous array of diseases and disorders, whereas the capability of a physician is only limited to his or her training in the medical field. And it's much easier for a machine to learn or to train on a lot more cases compared to humans. Okay, so compared to doctors, who's liable for misdiagnosis if the neural net is doing the diagnosis? That's a really good question, and I'm actually not very prepared to answer that right now due to that I'm not very knowledgeable about that fact. But that would be a very good question to bring up in the ethics discussions in the fourth week of this set of workshops. So I do encourage you guys to come to that and discuss it.
Yeah, just to jump in for that, that is one of the things that we'll be discussing in the ethics presentation. Just as a quick aside though, at the moment there is still a lot of debate about that as to whether it's the end user or the hospital or the software developers that are liable. So there are some hospitals that do see AI as, as any sort of like medical equipment, so then it's the user that's responsible, but there are still developments that are coming along in terms of that. But yeah, I'll just pass it back to you. So I'll just put in my 2 cents, Andrew. Yep,
that's all good. Yeah, like I don't know how to answer that question, man. I'm just a student. It's very contentious, extremely. But yeah, let's move on though. So, so we talked about convolutions and image recognition. Another really good example of where neural nets could be applied is or like one of the other major advances in neural networks is development of recurrent neural nets. How this one actually works slightly deviates away from any biological examples. As you can see here, it's really complicated. There's no point for me to go into any of the specifics of how it works. There's entire courses on that. But I like to think of it more as a circuit than a neuron. But like pretty much the general gist of it is that it introduces the concept of memory in neural network models. So information passes through a series of these recurrent neurons, or as you can see here, and only the most important bits of memory or data would be sort of left at the end of the model, and all the least important stuff will be forgotten essentially. And because if it's able to maintain the most important parts of information, it's extremely valuable, and it also contains a temporal component with prior information feeding into the model, impacting posterior information. So this is really, really useful in terms of two main areas. The first one is for reading and comprehending text, and we call this natural language processing. And the second one would be comprehending time series data. So it's moving on here. A really good example of natural language processing in play in medical diagnosis was the invention of Human DX, which is an application or online platform / forum for doctors and specialists to consult one another on unique and difficult cases. And it classifies cases via natural language processing to direct the key data to appropriate specialists. And it's an absolutely enormous forum. You know, it has a goal of recruiting at least 100,000 doctors by the end of the next 2 years. And that vast amount of data is only able to be sort of properly managed and properly and efficiently managed with the usage of neural nets. And yep, as I mentioned before, the other useful application for recurrent neural nets is time series data. And a really good example of how that can be applied within the medical field is if we look at EEGs. So EEGs essentially are what brainwaves, so how we detect brainwaves. And it shows, a good use for those is that it sometimes shows when someone is in a seizure. So you can see non-seizure EEG sometimes looks like this, and seizure ones are vastly different with a lot more sort of inflections. And normally you can just tell if someone has a seizure just by looking at them. But there are cases where of micro seizures where they're only detectable via EEGs. So it's valuable to look at these in terms of medical diagnosis. I think I'll just leave the chat on the side. Brainwaves, thank you. So people looked at this, right? It's like, oh, this is pretty cool. But what if we're able to detect seizures, right, using EEGs? So say non-seizure brainwave looks like this. And what if this is some sort of pattern within this cluster of EEG, which is indicative of an upcoming seizure in the next 5 minutes? And if we're able to predict that, that's extremely valuable and is potentially life-saving. So there's a lot of work into detecting that. And one of the good things is that because EEGs are time series data, we can use recurrent neural nets to sort of try to find these patterns, right? And so if we don't use neural nets, we just look at it, it's very problematic because the EEGs for different individuals are extremely different. As you can see here, all of these are non-seizure EEGs, but you know, you can't really tell any similarities between them. They're vastly different. And also, even if we can, it's impossible to monitor someone for 24/7 and look for the signs for the next seizure in the next 5 minutes, right? So we do use recurrent neural nets to try to implement and filter out all the noise within the data to find if there are patterns that may signify an imminent seizure. But based on this paper, they've tried a variety of different neural nets. One of the most interesting things that I found while researching this was that instead of actually using recurrent neural nets, it's actually better if we use convolutional neural nets. So if someone printed out a picture of the EEGs and just told a convolutional neural net to look at it in terms of image recognition, the prediction and accuracy is actually a lot higher than recurrent neural nets. So that's something to think about. And yeah, it's always nice to implement different ways in neural nets to try to solve a problem. But now I think we'll move on to why. So now that we've covered sort of some of the most promising parts of AI and types of AI, I want to talk about why and in what specific scenarios we want to use AI over doctors, or we want to use AI in conjunction with doctors for diagnosis. Well, one of the most common arguments for implementation of AI in neural nets is that it's very accurate. And as we've seen with the skin cancer example before with the skin lesions, neural nets do have the capacity to perform better than trained dermatologists. And neural nets is also a lot less prone to bias. And since doctors are humans, they are intrinsically subject to a wide variety of biases, as mentioned in the presentation before. And these things they can't control because they might not be aware of it. And in terms of medical diagnosis, this always talks about the two main ways of thinking. So you've got system one thinking, which is heuristics. It involves fast automatic judgments and almost like a reflex, right, based on past experiences. And you have system two thinking, which is called critical thinking. So these two systems are very different from each other and involves different parts of our brain when we think about it. And it even incorporates different metabolic pathways in our brain. And you might think that doctors use system two thinking in routine diagnosis and decision making, but research has actually shown that this is not the case. So if you look at the diagram on the right, it tells a pretty interesting story. So if we look at it, the diagram looks at the probability that a patient will receive a test for potential future heart attacks depending on their age, right? So as age increases, you can see that the probability that a doctor will prescribe the test increases. But in most medical literature, the recommended threshold for prescribing one of these tests is set at the age of 40, because we know that people age 40 or less is less likely to have a heart attack. But what this graph shows is that the difference between ages 39 and 40 is much more than it should be, and which objectively doesn't really make sense, right? Because if I'm 39 and 364 days old, the probability of me receiving a heart attack compared to me the next day, so when I'm 40, is not that much difference. But as you can see here, the probability of me getting prescribed a heart attack test is a lot different. So this is problematic because someone could be, arriving at the age of 40 with a really relatively close probability of having a heart attack, but he or she wouldn't receive the test because the doctor thinks that, oh, if you're not 40, you probably just, there's no point for you to get the test. So this is an example of system one thinking and bias, in which is in play when the doctors make the decision, which is sort of, I guess, showing the massive gap in this data. But if we're aware of these biases that exist in humans whilst building the prediction model, when building our neural net, and if we use the right data to build and calibrate this model, we're able to avoid these problems, which are currently present in terms of medical diagnosis. And also, if we think about, doctors being humans, that they subject to stress and, various emotional factors, and that might influence their decision making. Obviously, that means that the patients won't receive the best outcome. And, in terms of AI, it's very cold. It's purely mathematical. It's not subject to stress. It keeps working regardless of whatever happens to it. So that is a potential benefit of using AI, but there are just so many ways that AI is worse than humans. So one of the biggest things is that it's only able to perform tasks and solve problems it's specifically designed to do. So if you build an AI to detect, for example, lung cancer from X-rays, you would have no idea what to do if you give it a scan of a brain, right? Or it will do something, but it will just be completely wrong. So I'm just, okay. And the performance of AI is strictly limited by what data we give it to learn from. So if the data contains intrinsic biases and we don't pick up on these while we train the model or we build the model, the resulting thing will be extremely biased. And there's so many just horrifying examples of, models built on biased data. And if we actually apply them to real life scenarios, the results are catastrophic. Think about, I think a year ago, Amazon implemented an AI recruiting tool, which ended up favoring men for technical jobs a lot more than women because the data contained a lot more resumes of men compared to women. So that's a big problem, and that's extremely discriminatory, and that's something we definitely want to avoid. And Yeah, so in terms of the models that we covered in the presentation, they aren't emotional at all. So it's only good at making predictions. And in terms of medical diagnosis and in terms of communication, empathy, and addressing the emotional needs of patients, which arguably, in my opinion, is the most important aspects of medical diagnosis and healthcare, we still absolutely do need to rely on doctors to do these things. And one other thing is that neural nets are notorious for their lack of explainability. So it's able to tell you what the right answer is or what it thinks is the right answer, and it's able to do that very accurately, but it can't tell you how it arrived at that conclusion. So, which is extremely problematic in medicine, because if we want to like make a diagnosis, we have to be able to tell the patient why we want to make that diagnosis. And if we use a neural net, you know, we can't just say, oh, I don't know, the machine did it. That's not a good thing to do. And yes, the last point is that it's limited by the availability of data. So if you don't have enough data, you can't make a neural net to begin with.
If I can just jump in here, Andrew.
Yeah, sure.
So there are ways of interpreting how a neural net got to its solution. The problem is that it's not particularly explainable to someone who's not familiar with the neural net itself. So, for example, in the convolutions that you were looking at earlier in the workshop, you can actually see like, you know, this layer is picking up on these features in the image, and we'll talk about this in the future workshops, so don't worry about that. But where that's not particularly helpful is if someone's not familiar with the technology, for example, a doctor who may not have this background, that person is not going to be able to explain that to, say, a patient. So the explainability is a problem, but it's not entirely a black box. There are ways to peek into it.
Yeah, definitely. Thanks for picking up on that. So yeah, so if a doctor isn't the one that made the model, he or she probably wouldn't know how to explain what the model's predicting. And yeah, I think that was the end of my presentation. Does anyone have any additional questions or comments? Feel free to chuck in the chat. If not, we might move on to the next presentation.
If anyone has any other questions, feel free to shoot them in the chat, and one of us will get to you, shoot you a message. But yeah, Andrew, thank you so much for that presentation. We got a lot out of that, and I'm sure that it looks like a lot of people have a lot of questions. So yeah, keep them coming, and we'll try and get to them. So what we're going to do right now is I've got one last part in our workshops today, and we've actually got a special guest joining us, like we said before at the start. So Dr. Traversal is here with us, and he's going to be talking about some of his experiences you know, using AI in radiology. So like we said before, he is a medical doctor and researcher at the Alfred Hospital, and his research is at the intersection between artificial intelligence and radiology, applying deep learning towards problems in radiology. And he's also involved in Harrison.ai, which is a startup aiming to improve IVF outcomes through AI. So Gerald, thank you so much for joining us today. I'll get you to...
Yeah, no problems. Can you guys hear me all right?
Yeah, cool. I'll just put you on the spotlight right now. Awesome. Cool, take it away.
Cool. Yeah, thanks for the intro. As mentioned before, I'm Gerald. I'm a medical student at Monash. Well, was a medical student at Monash. I'm now a doctor at the Alfred Hospital. I'm also an AI engineer at an AI startup called Harrison AI, which not only works in IVF but also works in radiology, which is the area of my subspecialty training at the moment. So I'll just maybe talk a little bit about how I started working on AI in medicine first, and then I'll talk a little bit more about some examples of AI that we're currently using in practice, and you get to see it live. And you also talk a little bit more about some of my research, which links into what you were talking about before about explainability. So yeah, good talk about that before, Andrew. So essentially, I started really getting interested in this back in 2014 when I did my Bachelor of Medical Science. And that was in conjunction with the Monash robotics division at the time, and basically we were looking at a way to detect cervical spine fractures on CT. And so it was 2014, and deep learning hadn't really taken off, so we were still using some pretty old school stuff like Viola Jones object detection and graph cuts and that kind of thing. And so I spent my whole year working on it, and then at the end of it, I read the AlexNet paper and said, well, that was a waste of a year. Could have just done that. Yeah, that would be a lot easier, but that's fine. So basically, after that, I got really interested in this in its applications of radiology. As you probably know by now, deep learning's main strength is in looking at unstructured data like images, sound, text, and that's kind of basically a lot of what radiology is about. It's about taking unstructured information in the form of images and making some kind of interpretation out from it. Obviously, it's a lot more nuanced than that, but that's the primary job of radiologists, diagnostic radiologists anyway. So I started doing some research into this, and it obviously became quite clear. Number one, which is there's a few problems. Number one, there's not really wasn't at that point any good data sets, and so I had to go work with the Alfred in order to extract data out from there, and it's a completely whole different ball game. But we can go through there and then talk about that later. But the second point was about explainability, and so you talked about that before. I'm just going to share my screen. So one of the very first few things that you learn as a medical student or as an intern in your first interaction with radiology is probably chest x-rays. And if there's some medical people in this audience, you probably know that one of the main things that you look for on a chest x-ray is heart failure. And so that was the first thing we decided to go for, which is, can you predict heart failure from a chest x-ray? Of course you can. There's no question about that. The question is, can you figure out what it's looking at? And so one of the ways that we came across this is something called latent space traversal. And it's basically instead of trying to go from the original image directly to the prediction, right? The idea is that you encode the image into an n-dimensional vector, and then you decode that to basically reproduce the original image as accurately as possible. And then instead of predicting it directly off the image, you predict it off the latent space representation of that image. And the whole point of doing this is because now you've done that, you can actually permute this latent space and say, all else being equal, how would this patient look like if they didn't have heart failure? So you can take the same patient and you can redraw their x-ray without heart failure. And those two comparisons basically allow you to at least hone in a little bit on what the algorithm might be looking at. So there's a lot of questions about how it performs, and the technicalities about this. Basically, instead of training off whether or not a doctor's impression of whether or not there was heart failure on the X-ray, we trained it directly against something that was objective, which is a blood marker called the brain type natriuretic peptide, which measures the strain on the heart essentially. And so that's the objective measure of whether or not the patient actually has heart failure. But if you go and look at these GVRs, or what we call them as generative visual rationales. So this is let's see if it'll load. So this is an image of a patient's X-ray. So it starts off as the original X-ray, and it redraws it without heart failure. And are there any medical students in this audience? Nah. Okay, that's fine. So basically, it's shrinking the heart, and that's exactly what you expect, right? Which is, if you remember from your medical school lectures, one of the signs of chronic heart failure is enlarged heart. So far so good. It's doing the right thing. In order to predict whether or not the patient has heart failure, if you try to draw the patient without heart failure, it draws them with a smaller heart. That's fine. So you can go the other way. You can say, if the patient doesn't have heart failure, what would they look like with heart failure? So far so good. So it makes the heart bigger, and then it starts drawing in something up here, and basically it's drawing in a pacemaker, which makes sense, right? Because pacemakers are one of the treatments for heart failure. So all we've told it is have an image predict the B-type natriuretic peptide, and that's it, right? And then tell us, why would this patient have a higher BNP? Why would this patient have a lower BNP? And of course, one of the things is obviously people with heart failure are more likely to have pacemakers. So if you make somebody, if you ask you to draw somebody without heart failure as if they had heart failure, it gives them a pacemaker. So this is, goes back to the reason as to why interpretability is really useful and really important in medical imaging, which is there's a lot of confounding factors that one algorithm could look at. So even though it performs really well at predicting something, if you don't actually have a good explanation as to what it's looking at, it's quite difficult to trust the algorithm to make sure that it's actually not looking at sources of variability that you don't want it to. You can read it about the rest of the paper next time, but I'm just going to keep moving because we're going to run out of time if I keep talking about this specific paper. So I just want to show you now, you were talking quite a bit, I can see in the chat there was quite a bit of talk about, use cases and whether or not people are actually using AI in practice, or where AI tools are actually being used. This is an example of an AI tool that's currently being used at our hospital. And basically there are sort of three main areas in radiology where it can help. One is obviously at the time of interpretation. So, the scan has just been done. You're going to look at the scan and you say, does the patient have or not have a particular disease? We sort of call that assisting the patient, assisting the doctor. You can also do it in terms of triage. So you can say there's 100 scans on the list to be interpreted by a doctor. Obviously, the doctor can't look at them all at the same time. So you can assign the most important ones, or the ones that have something on it. And then this is and right at the end, there's another application that we call assure, which basically means now that the report has been written, get the AI to go back and check, right? So there are two components to that. There's an AI that reads this and says, does this talk about a lung nodule? And then there's another AI that looks at the actual CT and tries to find a nodule. And if there's a discrepancy, it comes up on a work list, and the doctors can go back and review it, right? And you can look at this nodule and decide whether or not it's real or not. And in this case, it is. So we have to go back and change the report essentially. So this is sort of like the three basic kind of applications in terms of computer-aided diagnosis and artificial intelligence in radiology. And if you want to look at another example of an assist device, so if somebody was going to be reporting something at that specific time, then you can look at, this is AI Doc, which is a system that's currently running live, and it picks up clots in the lungs and hemorrhages in the brain. And so that's pretty straightforward. So when the patient gets scanned, the scan goes through the algorithm and pops up. Yes, they're both being used at the Alfred right now. Last scan 1 hour, 15 minutes ago. Yeah, so that's basically radiology and some of the work that I've been doing. The other thing that I'm involved in, as Leah has quite kindly mentioned, is Harrison AI. So Harrison AI is a startup based out of Sydney. We are a bunch of doctors and a bunch of AI engineers. We like people who have both perspectives and the ability to understand, for instance, the importance of interpretability, but also have the ability to come up with algorithms that can solve that is really important to us. We work primarily in radiology and in embryology, but also looking to expand into other fields like pathology, or basically anything where image interpretation or AI can be used. So that's a little bit of a plug. And we're always interested in people who are about to graduate or who have interest in AI, always looking to hire new AI engineers. And that's really about all I have to say. I can talk a little bit more about some other projects if you want, but I'll leave that up to Leah, whether or not there's any other questions anyone wants to speak about first.
Yeah, awesome. Thank you so much for that, Jarrell. See if anyone has any questions. So does anyone have any questions that they wanted to ask Jarrell? Feel free to put your hands up or send anything in the chat and Gerald can answer some questions. I think someone asked about the programs that are being used in the Alfred. Could you talk a little bit more about that, Gerald?
Yeah, so we use a variety of AI programs in radiology at the Alfred. So one obviously is Ferrum, which is the one I was just talking about here. And this is the Assure workflow where every week this algorithm looks at all the CT scans that we've reported, and you can see here that's from July, and it tells us whether or not there's been a lung nodule or potential cancer that's been missed. And if we review all the discrepancies between the report and the actual CT scan, and if there is a significant discrepancy, we go back and we change the report. And obviously AI Doc, which is more of an assist thing, this happens in real time. So when the scan is done, this pops up immediately. So as we're reporting it, we can look at this and say, actually, there's something that's blocked up here. So yeah.
Awesome, sounds good. Got another question. So Julie asked, is AI being applied to cardiovascular research at all, to your knowledge?
Yeah, cardiovascular research is probably one of the very hot topics in AI. There's a lot of work looking at cardiac MR, at cardiac CT. These things give you, the cardiac imaging is different from normal imaging because it's a 4-dimensional study, like for cardiac MR. So in here you can see, for instance, a CT scan is a 3D volume, right? But a cardiac MR goes across time as well, because you want to look at the motion, and it's obviously a lot of information for someone to take in, and AI does things really well in that sense. And one application for instance, AI in cardiac MR is in tracking wall motion. So I'll show you what I mean. So traditionally, if you want to look at whether or not the wall motion is working well on an MR and the heart, you have to do this thing called cardiac tagging, where you actually put a particular pattern of magnetized protons. Essentially, you induce some magnetization across the protons in the body in a specific pattern, and the motion of the heart changes that image, right? And it's a very specialized technique, as you can tell. But what AI can do is it can look at the tissue characteristics of the wall itself and match that in a normal 4-dimensional MR. And so you don't actually have to do this specific technique, and you can still retrieve the motion of the wall. So that's one of the things that people do in AI in cardiac MR.
Awesome, sounds good. I've got a couple more questions. Looks like a lot of people have things asked. So Pravik asked, what are your thoughts on the seemingly widespread fear that AI will eventually replace radiologists? And Calvin's added, and also in pathology and dermatology as well.
Yeah, so there's this obviously famous video by Jeff Hinton now. I think some of you may have seen it, where it says we should stop training radiologists now because they won't need them in 5 years. I think it's a little bit optimistic. So the reason why I say that's optimistic is because of the combinatorial nature of the things that you're trying to detect on AI, right? So, for instance, in this single study, right up here, just specifics, I can already tell you, obviously there's a lung nodule, right? But there's subcutaneous emphysema, there's gas along the sides, right? And there's other things that are wrong with the scan. And the problem is, AI is very good at classifying whether or not something is absent or present. What it's not very good at is characterizing something. So if you want it to be able to characterize, say, the lung nodule, you need examples of, for instance, whether or not it's spiculated or not, whether it's calcified or not, whether it's containing fat or not, right? And all of those things eventually combine in a way such that it's very hard for you to cover everything in that data set. So AI will definitely make radiologists more efficient. It means that you don't have to read every scan, which is probably a good thing. There's some estimates that say that the volume of imaging in developed countries doubles approximately every 3 to 4 years. and our radiologist numbers are definitely not doubling every 3 to 4 years. So eventually we won't be able to keep up without AI, essentially.
So I've got a question from Quentin. Do you have any suggestions for any medical data sets that people can work with and learn more about neural networks?
Yeah, probably the best ones to start with are the chest X-ray data sets. So the NIH chest X-ray 14 data set is super well known. It's the labels are not that good. So this is not a problem with medical imaging data sets. Is the images are cheap, like in the sense that there's a lot of them. There's 41 gigabytes, 100,000 images, but the labels are difficult to get. All right, you need a doctor to sit down and basically label it, or you extract it from the report. And that's one of the main stumbling blocks for medical imaged AI at the moment. But yeah, I would definitely recommend starting with NIH chest X-ray dataset if you're interested in 2D medical imaging problems.
Oh, sounds good. Maybe we'll get someone to post that into the chat section later on so you guys can have a bit of explore. I think we just got one more. Oh, awesome. Thanks for that, Gerald. I think we've got one last question from Scott. What are you excited about for the future of AI in radiology?
Yeah, lots of things. I think a lot of the information in our images at the moment aren't being properly utilized. Right now, there's a lot of information in these volumes, like for instance, the texture of the lungs that we don't really look at, and AI has the potential basically to uncover a lot of features that we might not be aware of as doctors, right? Every now and then people, radiologists stumble upon some kind of interesting correlation between a particular image feature and the disease type or prognosis, but that's a very sort of slow process, and you can definitely accelerate that with AI.
Yeah, awesome. I think that was all the questions for today. Thank you so much for joining us today, Gerald. Everyone seemed to have a lot of questions, and we definitely got a lot about different out of your presentation. And if anyone has any other things that they'd like to know about, shoot a message in the group chat, or someone's also linked the episode of Gerald's webinar for MYMI. So if you want to hear a little bit more about what he does, definitely check that out. So that concludes the end of our workshop. Before we finish off, I'll just pass over to Mitchell, who is going to be running workshop 2 next week. So he'll just talk about a little bit as to what you can expect in the next couple of weeks.
All right. Minor clarification. Sean is going to be running next week. I'll be running week 3.
Yes.
But essentially what's going on here, Sean is going to be covering some basics on image classification. Essentially what we're going to be looking at is training an AI to tell the difference between infected and uninfected cells with malaria. We'll be going over, I guess, we'll be using FastAI, which is written in Python. So if you haven't used your Python in a while, this is a good time to brush up over the next week. The week after that, we're going to be looking at how to put that model that you train in week 2 into production. And that will be using a bit more of the Python concepts, because that isn't something which is abstracted away by FastAI. So we'll be implementing our class ourselves. So you're not going to need things like classes in next week, but that's probably the upper limit of where you need to go with your Python skills. But beyond that, FastAI has some excellent tutorials if you want to have a look at things ahead of time, but it's not necessary for the workshop. So make sure that you understand your Python and you'll do fine.
Awesome, thanks for that. And yeah, so that concludes the end of our workshop. We hope that you guys had a good time and that you learned something from today's presentations. We'll see you guys next week for the next set of workshops. So just keep a lookout in your emails for the workshop link for that. And yeah, apart from that, we'll see you guys later. Bye guys.